Good afternoon and welcome to the Subcommittee on Oversight and Investigations hearing on the Defense Department's efforts to monitor and control outbreaks of multi-drug-resistant infections that have occurred in military hospitals over the past several years. While the U.S. military has provided high-quality health care for service members wounded in Iraq and Afghanistan, infection outbreaks caused by multi-drug-resistant bacteria emerged as a problem early on during military operations. One of the pathogens with the most notoriety is Acinetobacter baumannii. Incidentally, any pronunciations are my own, and any resemblance to the actual pronunciation is clearly coincidental. So, Acinetobacter baumannii, a group of opportunistic bacteria which can accumulate antibiotic resistance relatively quickly. The only treatments available to fight the infections in some cases are highly toxic older drugs that can cause harm to a patient's health. According to the DOD, over 3,300 service members developed Acinetobacter infections from 2004 to 2009. While the bacteria are found in the natural environment, evidence suggests that the source of infections was in the military hospitals. Contamination in these hospitals placed other patients at risk. Outbreaks of multi-drug-resistant infections have created management challenges for the military. Initially, the source of infections was difficult to identify because wounded personnel are evacuated through several treatment facilities before reaching a medical center in the United States. Also, determining the nature and extent of the problem took time because infections did not show up in patients until days after an injury, and screening and surveillance capabilities were limited. Moreover, implementing infection control and prevention measures in combat hospitals are challenging given the physical conditions and limited infrastructure available. The lack of infection control expertise at these facilities, as well as limited experience in treating multi-drug-resistant infections, compounded efforts to manage outbreaks. In the past few years, the number of infections in military hospitals has decreased significantly, in part because the total number of combat casualties has gone down, but also because DOD and the services have implemented measures to strengthen infection screening, control, and prevention in the military healthcare system. Steps have been taken to promote awareness and basic infection control practices, such as using new gloves and gowns with each patient. Guidelines for isolating patients with suspected multi-drug-resistant infections and more targeted use of antibiotics were implemented. Additional infection control training is now available to deploying medical personnel. Furthermore, standardized screening for multi-drug-resistant bacteria has been instituted at the major military medical centers. Lastly, research has been conducted which has led to a better understanding of the risks and treatments associated with multi-drug-resistant infections. While considerable progress has been made in controlling infections, the problem has not been solved, and new outbreaks will be a continuing challenge. According to some service officials, there is a need for 1, a more comprehensive surveillance system to monitor infections, 2, enhanced training and expertise in infection control, 3, a coordinated and sustained approach to research and development, and 4, perhaps an infection control consultant in each combat theater. The incidence of drug-resistant infections is a national and global problem in both the civilian and military world that has grown dramatically over the past decade in civilian hospitals. According to the Centers for Disease Control and Prevention, almost 100,000 Americans are killed each year by hospital-acquired infections. Health experts warn that the problem could get worse in the next several years because there are few new antibiotic treatments expected from the drug research pipeline. Because patients with severe injuries are most susceptible to these infections, DOD and the services must remain vigilant in their efforts to monitor and prevent them. The purpose of this hearing is to examine how the Department of Defense has responded to outbreaks of multi-drug-resistant infections over the past several years, and whether effective surveillance, prevention, and research programs are in place to manage this challenge in the future, and what Congress can do to help. That concludes my opening statements. Congresswoman Louise Slaughter has had an interest in this issue of multi-drug resistance for some years now, and I would ask unanimous consent to include as an addendum to my opening statement a statement from Representative Slaughter. And we now recognize Mr. Whitman for any comments he would like to make.
Well, thank you, Chairman Snyder, and good afternoon to our witnesses. Thank you so much for joining us today, and thank you for your service to our country. You know, it's easy to start a debate or to find a contrary view on almost every issue that arises here in Washington. The good news is that the subject of today's hearing is that rare exception to the rule. You know, there's no political party, no healthcare provider, and certainly no patient that wants any part of infection, much less the virulent infections that are the subject of today's hearing. Multidrug-resistant organisms, or MDRO, are a serious matter for both our military and civilian healthcare providers and are with us to stay, I fear. I understand that infection control demands constant vigilance in medical facilities, requiring careful training and strict adherence to proper procedures within all areas of military treatment facilities. Infection control is particularly difficult in an austere deployed setting with limited supplies, limited access to fresh water, and the necessity of handling potentially large numbers of casualties who have been living in a field environment. I traveled last spring to Afghanistan, and after a single day was covered in a significant layer of dust. So I can tell you, after moving through Kandahar province, I have a deep appreciation for what you all have to deal with downrange. And I can only imagine the condition of troops living in the field for months at a time, just based on my short experience there. So I know infection control under such circumstances must be daunting. And we're all glad to see that the growing problem of gram-negative bacterial infections in military facilities was identified several years ago, and that considerable progress has been made in screening for and controlling these infections. In fact, the number of cases of the most virulent bacteria was cut by almost 2/3 in military facilities from the peak. My hat's off to you on that. Still, improvements can be made in enforcing infection control protocols, in reporting mechanisms, and in research for both the better treatment and better control procedures. We on the committee fully support your efforts in this area, and I look forward to hearing from you on how we can help to continue to make progress in combating infections of all types. I look forward to your testimony today, and again, thank you so much for what you've done, and thank you in the future for what you will do in addressing this daunting issue. And Mr. Chairman, with that, I yield back.
Thank you, Mr. Whitman. Our witnesses today are Dr. Jack Smith, the Acting Deputy Assistant Secretary for Clinical and Program Policy, Office of the Assistant Secretary of Defense, Health Affairs. Colonel Dr. Jonathan Jaffin, Director of Health Policy and Services, Office of the Army Surgeon General. Colonel Dr. Dwayne Hospenthal, Infectious Disease Consultant to the Army Surgeon General and Chief of the Infectious Disease Service at Brooke Army Medical Center. Colonel Dr. James D. Collier, Assistant Air Force Surgeon General for Healthcare Operations. Lieutenant Colonel Dr. Michael Forgione, Infectious Disease Consultant to the Air Force Surgeon General and Chief of Medicine at Keesler Air Force Medical Center. Captain Dr. Gregory Martin, Infectious Disease Consultant to the Navy Surgeon General and Program Director of the Infectious Disease Clinical Research Program at the Uniformed Services University of the Health Sciences. And Ms. Judith English, Navy Bureau of Medicine Surgery Infection Control Consultant. Thank you all for being here. Somewhere we have a clock that you can see. We'll turn the clock on for 5 minutes. When the red light starts flashing, it means 5 minutes has gone by. If you have more things to say, let us know. Otherwise, we will get to our questions. We have 7 witnesses, but only 4 of you actually are doing opening statements. And we'll begin with you, Dr. Smith.
Chairman Snyder, Ranking Member Whitman, members of the committee, thank you for the opportunity to discuss Department of Defense efforts to address the growing challenge of healthcare-associated infections, particularly those from multidrug-resistant organisms, or MDROs. We greatly appreciate the committee's interest in this important issue and its continued strong support for the dedicated men and women of America's armed forces. Mr. Chairman, as the committee so well understands, healthcare-associated infections, including those from MDROs, are a serious problem for the military, but also represent a growing problem in healthcare facilities across the nation. These pathogenic organisms, which are predominantly bacteria, have not only increased the length of hospital stays, but also mortality rates. So the problem is quite serious and one that we must continue to address. The sources of these bacteria and infections are multifactorial, with both environment and facility-related factors. In hospital settings, they are most likely to contaminate environmental surfaces, equipment such as ventilators and dialysis machines, the hands of healthcare workers, visitors, and family members, and the respiratory, urinary, skin, and gastrointestinal tracts and wounds of hospitalized patients. Accumulated data have shown that transmission of MDRO infections in combat wounded service members who have returned to the U.S. does not appear to have a single source or involve a single strain of bacteria, but rather are derived from multiple sources and must be addressed as system issues. DOD has been actively engaged in measures to screen, surveil, prevent, and control infection in military treatment facilities at home and on the battlefield. The military health system maintains a quality assurance program implemented in all military treatment facilities that establishes policies and procedures and requires training of our personnel to minimize the risk of infection to patients and staff, control the spread of infection, assess patient care, review healthcare records, and manage health resources and risk. We've also established an infection prevention and control panel with service subject matter experts as a subcommittee of our Military Health System Quality Forum. The Global Emerging Infection Surveillance and Response System, of a division of the Armed Forces Health Surveillance Center, is a central hub that leverages the surveillance and response assets of the services and oversees military medical research units, and is paving the way for laboratory standardization for microbes of military interest. The Multidrug-Resistant Organisms Repository and Surveillance Network System, established by the Medical Research and Materiel Command, is working to rapidly characterize emerging drug resistance threats, track and monitor MDRO patients, and reduce the risk of healthcare-associated infections, which will aid in the development of a daily alert surveillance system for MDROs of significant importance. Since December of 2008, the Military Health System has been participating in the Centers for Disease Control's National Healthcare Safety Network. Currently, 33 of our military treatment facilities are participating. We're also participating in the American College of Surgeons National Surgical Quality Improvement Program, or NSQIP, which is focusing on, among other issues, the occurrence of surgical site infections which could involve MDROs. And the Joint Theater Trauma Registry is adding an infectious disease module to study and better understand the risks, interventions, and outcomes associated with combat trauma. Standard infection prevention and control practices and standard clinical practice guidelines have been established and implemented in both garrison military treatment facilities and deployed areas. Admission MDRO colonization screening is performed at the 4 major receiving military medical centers for OEF and OIF wounded: Landstuhl Regional Medical Center, Walter Reed Army Medical Center, National Naval Medical Center, and Brooke Army Medical Center. Patients are not released from contact precautions or isolation until they screen negative, and screening results are collected, reviewed, and reported. And DOD partnerships have been established with the VA and the CDC to address the challenges presented by MDRO and other infections. In addition to screening, surveillance, prevention, and control, DOD has numerous studies underway to further our understanding of MDRO and other infections, to enhance the prevention and control of infections and develop new treatments and therapeutics. Several DOD research laboratories receive funding to conduct research on MDROs, including Walter Reed Army Institute of Research, U.S. Naval Research Laboratory, U.S. Navy Medical Research Center, the Institute of Surgical Research, the Armed Forces Institute of Pathology, and the 4 major medical centers already mentioned. Mr. Chairman, the Department shares the Committee's concerns about the threat of multi-drug-resistant organisms, and we're working to improve our preventive measures, treatment, surveillance, and research as we respond to outbreaks of MDRO and other infections in military personnel and facilities. We appreciate the Committee's interest in this important issue, and I'll be happy to respond to any questions you may have.
Thank you, Mr. Secretary. Colonel Hospital, I think you're next. You're recognized.
Chairman Snyder, Representative Whitman, members of the committee, thank you for this opportunity to discuss U.S. Army efforts to prevent and treat multi-drug-resistant organism infections. As you've already pointed out, multi-drug-resistant organisms have increasingly become a healthcare threat in the U.S. and throughout the world. Focus in the U.S. and abroad to control these infections has included attempts to prevent transmission within our hospitals and other healthcare settings. These efforts have been championed by the Joint Commission through patient safety goals and by the Centers for Disease Control and Prevention through guidelines in the prevention of MDROs. Since the onset of Operations Iraqi and Enduring Freedom, infections and colonization with MDROs, especially MDR, Acinetobacter, and the extended spectrum beta-lactamase producing E. coli's and Klebsiellas have complicated the care of our injured U.S. military personnel. The source of these bacteria in returning combat injured personnel has not been fully elucidated, but it appears that most likely these bacteria are spread nosocomially, both in the combat theater, along the journey back to and within military medical centers in the United States. In addition to routine practices and participation in U.S. civilian healthcare standards, which I've mentioned, the military healthcare system has responded to these problem with specific efforts focusing on ameliorating the problem in returning injured personnel. And these efforts include the emission MDRO screening, which Dr. Smith has discussed, development of specific guidelines to prevent infections in the combat injured, efforts to improve infection prevention and control in the combat theaters, establishment of an MDRO repository and surveillance network, and enhanced research efforts. Mission MDRO colonization screening is performed, as mentioned, in the 4 major receiving medical centers. Patients are not released from contact isolation until they screen negative. This provides near real-time monitoring of the rates of this colonization and potential infections in evacuated personnel to feed back to the combat theater. Clinical practice guidelines developed by a consensus conference, including the Army, Air Force, Navy, and civilian personnel, have been produced and promoted. These guidelines for the prevention of infection after combat-related injuries have focused on limiting antibiotic overuse and basic infection control interventions in theater. Critical review of infection control practice and challenges in the combat theater hospitals was conducted by myself and Colonel Helen Crouch in 2008 and 2009. These review missions produced multiple interventions to improve our infection control in a deployed setting, and this includes renewed emphasis and focus on basic infection control methodologies and practices, development of electronic resources and web pages, deployment of clinical microbiology and antibiotic control, as well as the establishment at the Army Medical Department Center and School, a short 5-day course for identified infection control officers for deployed level 3 hospitals. Also, a standardized infection control policy was produced and is being staffed currently in the Afghanistan theater. The repository established to collect and study MDROs was established in June of 2009. The MDRO, or Repository and Surveillance Network, the MRSN, was established to collect and characterize bacterial isolates and provide epidemiological data to manage this problem. In conjunction with clinical and transportation data, the MRSN could help localize sources of MDROs to enhance and focus infection control methods. And data from the Joint Theater Trauma Registry will be essential to this effort. Over the past several years, the DOD has enhanced and expanded research in the prevention and treatment of MDROs. The Army is committed to aggressive efforts to prevent and treat MDRO infections. This includes a commitment to continued research aimed at understanding, preventing, and treating these infections. Additional efforts are underway to prevent transmission of MDROs within our military hospitals. We join civilians and other federal agencies in our commitment to combat the spread of MDRO infections. Thank you again for this opportunity to address the Army's efforts, and thank you for your continued support to our nation's soldiers.
Thank you. Captain Martin.
Chairman Snyder, Congressman Whitman, distinguished members of the subcommittee, I'm pleased to have the opportunity to update you on Navy Medicine's response to the problem of multi-drug-resistant organisms. As a Navy Surgeon General Specialty Leader for Infectious Diseases and a practicing infectious disease physician at Bethesda Naval Hospital, I can assure you that this issue is vitally important to the Vice Admiral Robinson and to all of Navy medicine. One only has to listen to NPR or watch the evening news to understand that the threat from multi-drug-resistant organisms has really become a global issue. The Infectious Disease Society of America, the Institute of Medicine, and the World Health Organization have all identified resistant infectious agents as major public health threats for which a coordinated global effort is urgently needed. The DOD has been a national leader in identifying and addressing the MDRO challenge. While focused on the combat injured, many of whom have survived overwhelming blast injuries with burns and amputations, the reality of treating these infections has been sobering. In some cases, MDRO infections have been responsible for persistent infections leading to delayed healing, amputations, or sepsis. MDRO infections in our combat injured were first identified in 2003 on the hospital ship Comfort and at Bethesda. The Naval Hospital began screening of OEF patients for MDROs and instituted infection control measures to prevent their acquisition and transmission among patients and staff. Bethesda screening was then adopted in each of the major casualty screening centers in the U.S. and in Landstuhl. Our Army colleagues deployed an expert team to treatment facilities and theater to assess infection control measures and ensure that standard precautions were being adhered to, even in forward treatment areas. Their efforts led to changes in practice in all three services, with cohorting of long-term patients separately from the acutely injured patients who are unlikely to harbor MDROs and were typically being medevaced back to Landstuhl and CONUS Army and Navy facilities. Furthermore, infection control training needs were identified and a pre-deployment infection control course made available to each of the services. Establishment of the MDRO repository and surveillance network to collect isolates will enable a more definitive molecular analysis of the relationships among the MDROs, as well as common sources for their acquisition. As our patients transfer between hospitals of the different services, all DOD MTFs will benefit from the repository system. Most importantly, our patients, their families, and our clinicians would like to know what can be done to limit the harm these infections inflict on our wounded warriors. In this regard, Navy BUMED has funded the Trauma Infectious Disease Outcomes Study, or TDOS, to combine surveillance, laboratory, and clinical data from combat injured patients and follow them through their subsequent care in VA hospitals. The DOD is uniquely capable to develop a program like TDOS that can monitor a large group of patients and develop evidence-based recommendations that will be utilized not only in the care of an injured Marine from Afghanistan, but also the high school student with an infection after a car accident. In the last few weeks, the TDOS project has expanded to include the VA hospitals and is now one of the first medical programs to bridge the military to the VA transition. We are enthusiastic that TDOS will provide the data to assess our treatment of combat-related infections and effect changes in practice that will improve future outcomes. Overall, I feel the response of the DOD ID and infectious control communities to the worldwide threat of MDROs is something that we should be proud of. Careful surveillance, coordinated interventions, and increased research efforts are helping the Navy and the DOD to remain at the forefront in the response to MDROs. I appreciate the opportunity to have updated you on our efforts and look forward to your questions. Thank you.
Thank you, Captain Martin. Colonel Collier.
Chairman Snyder, Representative Whitman, good afternoon, and thank you very much for this opportunity to discuss this critical issue with you today. The Air Force is working diligently with our sister services to control infectious diseases in theater and in our medical treatment facilities. As you are well aware, this problem continues to challenge the medical community in both public and private sectors around the globe, and we appreciate your support in our endeavors to address it. As I am the last to speak, I will try not to be redundant to the previous witnesses and have submitted my full statement for the record. In response to the challenge of treating and managing MDRO infections in our returning service members, the DOD has instituted coordinated tri-service efforts in the areas of infection control and prevention, in surveillance, and in research and development. I will speak briefly about Air Force infection control initiatives. The Air Force is committed to infection control throughout our continuum of care. The most common patients in our Air Force theater hospitals to develop MDRO infections are those who remain in intensive care units for extended periods of time. Active duty ICU patients are stabilized and sent to Landstuhl Regional Medical Center or CONUS hospitals as quickly as possible. In contrast, injured and ill host nation patients have very limited resources for long-term medical care within their country, thus they tend to stay longer in our theater hospitals. This population is the one most susceptible to MDRO infection and colonization. Our theater hospitals have a physician and nurse as the infection control officer and representative to provide ongoing oversight and promote continuing awareness of infection control standards. They conduct surveillance, provide educational briefings on antibiotic resistance issues and wound management, and emphasize basic infection control efforts to prevent spread between hospitalized patients throughout the deployment rotation. The Air Force also has a specific package, the Expeditionary Infectious Disease Team, which is available to provide dedicated infectious disease and infection control assets for the theater surgeon. As the primary source of patient transportation from theater hospitals to Landstuhl and back to and throughout CONUS, aeromedical evacuation is the linchpin of our healthcare continuum. Our AE crews are trained annually in infection control. In addition to the usual standard precautions, crews are trained to mitigate the risk of transmitting nosocomial infections in the operational environment. They are trained to disinfect equipment and have in-flight kits that contain both spill kits and personal protective equipment. Further, hand sanitizer is placed throughout the aircraft cabin. AE personnel are also educated about airflow in our different airframes and where best to position patients to avoid the spread of infection. The Air Force has formal infection control courses that are conducted at Sheppard Air Force Base in Texas. There are 3 levels of training provided. for those assigned to infection control positions, both officer and enlisted, on the active duty side, for those assigned as the infection control function and committee chairperson, and training specific for our reserve component members. We also utilize equivalent civilian infection control courses. The new draft of our Air Force instruction titled Infection Prevention and Control Program has added an optional element which suggests that an active duty officer serve as the infection control assistant and rotate through the infection control office in those facilities that have a civilian infection preventionist assigned. This is designed to facilitate actual hands-on management of the infection control program in garrison for active duty officers so they may gain experience prior to deploying. While none of our Air Force MTFs consistently receive combat-injured U.S. personnel at this time, our medics do practice in all of the major MTFs responsible for the care of these patients in all of the major MTFs, which include forward-based hospitals and, as I mentioned, in our aeromedical evacuation system. An MDRO colonization screening process of OIF and OAF wounded upon admission is now in place, and encouragingly, a recent review of this data has shown a significant decrease in the number and percentage of patients colonized with Acinetobacter upon arrival at Launchstool and the 3 Level 5 CONUS facilities. While much remains to be done and understood to control or eliminate this complex medical dilemma, we continue to work with the world's foremost infectious disease experts to find the answers that will prevent future patients from contracting an infectious disease. From others in the very environment designed to protect and heal them. Whether they are our military and family members here in CONUS or our wounded warriors in theater, we must find a solution to this constantly evolving challenge. We appreciate your support, Mr. Chairman, and that of the committee as we seek to achieve this daunting but critical goal. Thank you.
Thank you all. Thank you all for being here. Colonel Collier, I think you were the only person brave enough to try your own pronunciation of Acinetobacter, so we applaud you for that. Well, Mr. Whitman and I will put ourselves on the 5-minute clock, whoever the timekeeper is here. When you think about what this means for families and the individual to have been wounded, moved to a military facility in country, moved to Launchstool, come back to the United States, get put into one of our military hospitals, have family members probably down there by then, and then to develop one of the infections and have things go south very rapidly must be just heartbreaking for not only for the family but also for the healthcare providers that try to take care of this person. And Dr. Smith, I'll ask you the question, but then I'll let you defer to whoever you want to. I'd like a little tutorial if I could get one on IED injuries, and if the fact of a blast effect in addition to an open wound, if that's a factor in these infections.
Well, sir, I'm certainly not an expert on IED injuries, but as we all know, they have become quite a problem for us in DOD during the course of this war. I believe we do have Colonel Hospenthal, who perhaps could respond to that, or.
Sure. I mean, certainly the blast injuries from IEDs cause tremendous tissue damage and devascularization. Initially, when we were looking for a source of these MDROs, we were concerned of whether there were some of the bacteria in the soil and organic debris were actually being lodged up in organic fragments and such. And so certainly it doesn't look like that is the main cause of these MDRO infections, but certainly the damage that's caused there has to be carefully debrided while trying to save tissue. And so devitalized tissue the surgeons may need to go back multiple times to try to debride off the dead parts of the tissue to allow the vascularized surviving tissues to survive. All during the while there's pressure or colonization with bacteria, like we have bacteria always on our bodies, and in the hospitalized environment, these bacteria are all often these multi-drug-resistant bacteria that then colonize these wounds and can cause the infections that we see.
And Colonel Jaffin, you have some comments concerning this?
Sir, I guess I'm the only surgeon up at the table, but what we see, especially with the large blast injuries, is a lot of separation of tissue along the tissue planes, that there is disruption of the vascular supply leading to large amounts of tissue. And so in order to minimize deformity and dysfunction, we try and preserve as much of that tissue as we can. At the same time, we're caught trying to make sure that we remove all the tissue that is not viable. That non-viable tissue is a great culture medium for any organism, and that's why the importance of the infection control measures to prevent colonization with the multi-drug resistant organisms.
In terms of the availability of research dollars, you all have your own budgets, and we have a lot of activity going on with NIH. I don't have a sense of the adequacy of research dollars available to you all for looking at this issue. Is it adequate? Is it inadequate? It seems like it actually went down from over the last couple of years. This is in the area where Congress can help. If we're not doing our job, you won't have adequate research dollars. Dr. Smith or anyone else want to comment?
Yes, sir. I'll begin with what's budgeted at the DOD level. We have currently in this fiscal year $13.68 million allocated for studies related to multi-drug-related organisms, or multi-drug-resistant organisms, I'm sorry. 10.25 of that in antimicrobial countermeasures, and 3.43 of that in wound infection prevention and management. And the services do allocate some research dollars, I believe, as well, to MDROs and infectious disease issues, and I'll let the services speak to those.
I think that's your cue.
Do you have figures for Army MIDRIP or?
I can probably take that, sir. For MIDRIP, there's about $430,000. For the specific on wound infections, there's an $895,000. U.S. Navy wound infection research also gets money. I don't have the exact number right here. USIS has a little over $4 million. Excuse me. Congressional Special Interest projects on wound infection, there's almost $12 million. SBIR project is about $3.7 million. Dr. Smith spoke about the defense health programs, and then war supplemental intramural projects, there's about another $2.5 million, sir.
Anyone else have any comment? Dr. Smith, now I thought that the upcoming, you said that was the current fiscal year. I thought the estimate is there's actually going to be a drop of several $1 million from your almost $14 million. Is that correct?
Sir, I don't have figures for FY11 or beyond at this point. Okay. It's my understanding that money has been palmed for this area of research. And in addition to that, there's incremental funding of programs in the out years, so that if there's promising research that has been identified and is ongoing, then that is often funded in the year of execution.
Now, in your opening statement, you described that, Dr. Smith, as vigorous research funding. It doesn't seem incredibly robust to me. Am I wrong? I mean, it seems like this is a huge problem. It's a huge national and international problem. You got major facilities around the world. It seems like that money would be stretched out pretty thinly, pretty rapidly. Is that a fair statement?
I'm not sure that I used vigorous funding, sir, in my statement.
I think it said vigorous research.
We certainly do have funding allocated for research, and this is very definitely an important, a vital area of interest for the military. But as you pointed out, it's also a national problem, and we're collaborating with, coordinating with National Institutes of Health and other organizations that are devoting research dollars to this. We do have to balance our research funding in this area with other areas of military research interest. So it is in a competitive process, but as I say, we have 13.6 million for this year.
I think your opening statement on page 6 says the DOD has a vigorous research program. And around here, when we hear vigorous, we automatically think of funding, I guess. Mr. Whitman, I went over my time. Mr. Whitman.
Thank you, Mr. Chairman. I'll begin with Dr. Smith, and I'd like to get the perspective, too, of the other folks here from the different service branches. I want to focus on the element of training and the element of deployed infection control officers downrange. First of all, I'd like for you to give us an overview about the scope and breadth of training that our infection control officers receive, that our infection control personnel receive, and our medical care personnel receive, both in a deployed situation and back stateside, and then also to determine how are those individuals deployed downrange? What mixture of personnel do we have there? Is there a specifically assigned officer in charge of infection control at these medical care facilities downrange? Who are those personnel? I understand in the past that there were nurses that were assigned as the infection control officers. Is that still the case? If you could tell us a little bit about the extent of training and then how those individuals are deployed in our medical care facilities.
Yes, sir. Well, I'll begin with the policy level and work down probably as far as the stateside facilities, and then pass it to my service colleagues to speak a little bit more about the deployed environment. But of course, infection control is an element of the training of all medical professionals now. So our physicians, our nurses, our corpsmen, our technicians are all being trained in their basic professional training about infection control. There also is Joint Commission accreditation of our inpatient facilities, and we have ambulatory accreditation of our outpatient clinics, which have initiatives focused on infection control. Infection control programs are a requirement for accreditation in those, and along with that goes appropriate training and orientation of staff in the facility level infection control programs. I do know that in the pre-deployment setting, DOD is also providing some additional training for personnel, but would urge that we keep in mind that the people who are deploying into the operational setting are the same people who have been providing the care back in the medical treatment facilities. So certainly the professional fundamental training, the infection control specific training that they're getting and utilizing every day in our military treatment facilities is useful as they deploy to that operational environment. And there has been pointed out in some of the testimony some of the challenges of practicing good infection control procedures and prevention in that austere environment. That's very definitely a critical factor. But let me pass to my left and ask whether the services would like to comment on the deployed environment.
I would agree with everything Dr. Smith has just stated. Certainly as medical healthcare professionals, we all receive nearly continuous training in infection control because it's become such a big issue throughout the world. In the deployed setting, certainly all the medical personnel have been working in hospitals and do have the basic training. Our mission in 2008 to review infection control practice and challenges revealed that there really wasn't well-trained, dedicated infection control officers, so the person in charge of the program at the level 3 facilities. It wasn't that the personnel weren't doing infection control or weren't doing a pretty good job, but the infection control officers that we've seen downrange really had not had more training and additional training, and often they were nurses, and often they really didn't have dedicated time to do their infection control officer duties. And that's really the challenge that we identified and focused on over the last several years, developing the kind of just-in-time 5-day infection control officer course, and getting policy changed on the Army side to stress infection control. Recently there was an XORD actually this week that went through that makes it a requirement that as the caches, as the combat support hospital break into separate pieces rather than operate as one single unit, that each one of those pieces or slices, as we call them, that have inpatients have an infection control officer who has been trained in either our 5-day just-in-time course or who have experience. And I believe this problem has really developed because of the operational tempo. We have a lot of hospitals downrange. We've been there a long time, and these hospitals are not operating as a single cache. They are broken into multiple segments, and because of that, we just did not have enough infection control officers trained throughout this.
I really have to defer to my the two previous colleagues, because I think most of what they've said really refers to all of us. Since all of these in-theater hospitals are really tri-service, we talk constantly. I mean, I am on a constant first-name basis with all of these guys, and we know what's going on, who's going where, and we have a pretty good handle on the issues. I think, as Colonel Hospenthal just brought up, earlier on in the war, things were a little less organized as far as what we knew was going on. And now the focus on infection control is much more evident at all of these facilities, both in CONUS and OCONUS. So I think that we are really have a much better handle on ensuring that infection control practices, standard practices, are being met even at a much more forward setting than we had previously. I also have with me Ms. Judy English, who's our Navy infection control leader consultant. And any comments about specific things that you would want to bring up from the? She is an infection control nurse, and I think she's one of the only nurses we have in here. And it's been an important thing for Judy to be at BUMED, because I think it emphasizes just how important infection control is to the Navy, in both in CONUS and OCONUS.
Thank you. Thank you, sir. The Navy infection prevention and control arena has been trying in CONUS to civilianize, so that at this point in time, 68% of our infection preventionists are civilians. And I have a monthly video teleconference and digital conference online that is 2 times in the day, so people all over the world can sign on. And this is for management and education purposes. And we do this continuously, as well as the usual getting together. We are also working with the Army and the Air Force as members of the TMA Infection Prevention and Control Panel. And we are now going over the data that Army, Navy, Air Force are all entering into the CDC's National Healthcare Safety Network, relevant to central line-associated bloodstream infections and ventilator-associated pneumonias in babies through the elderly in critical care. And now the Navy is working with the Navy Marine Corps and Public Health Center with beta testing sites to document all MDROs that are in CHCS, so that as soon as the Centers for Disease Control can accept HL7 download of these data, the entire Navy MTFs and DTFs will immediately go into downloading all the MDROs, working with DOD and CDC, and this will be another benchmark data that is not as high as the pulsed field gel electrophoresis that's going on, but this is the best that we can do without higher technology. This will be 21st century technology download as soon as CDC can accept these data.
Thank you. I think in the Air Force we mirror our sister services in our in-garrison performance, although because of the small size of most of our facilities, it is a dual-hatted position. Downrange, we also dual-hat it, but those personnel have to have passed the training level required of an infection disease preventionist to get that position in our downrange hospitals. The only additional place where we can carry out additional training then is our aeromedical evacuation business, and the aeromedical evacuation crews do receive additional training in order to understand how that works on an otherwise dirty airplane. So, yes, sir. Thank you.
Thank you, Mr. Whitman. Maybe we'll start with you, Colonel Collier, and go the other way, or maybe you can speak with the whole group. But in terms of the development of new drugs, I mean, those are expensive research projects to try to come up with a new drug. How much is the military or military patients involved in research looking for the next generation or a new kind of drug to deal with these infections?
Sir, I'm not able to answer that question, but I would ask my colleague if he has some input.
Thank you. As far as the Air Force's position in that, we do participate in clinical trials through the Infectious Disease Clinical Research Program that is stood up at USHS and is NIH collaborative as well. And so we do occasionally have patients that will participate in large multi-center trials. As far as a direct research initiative in the Air Force looking for new drugs, we do not have that service at this time.
This is kind of a difficult question because the DOD is not really set up well to develop new antimicrobial agents. I mean, that's really probably such an expensive and difficult undertaking that Big Pharma is really the only ones with pockets deep enough and with the ability to develop a lot of new antimicrobial agents. Whereas the DOD, especially the Army, has developed all the antimalarials we have, and we have a pretty good system for looking at that. It would really not be in our best interest for the DOD to start down looking at the very basic science needed to do a lot of the regular antimicrobials. So what we've done, I think, is focus more on some of the things that we can work on, and that's the clinical side of it. So we are doing some testing on some agents that have generally are not approved in the United States now, that have been funded, some Japanese products, some other drugs that are really, because we're already talking about second and third line drugs we're using for some of these, we're looking at doing some studies with those clinically. I think the more important thing is that we're able to collect a lot of these different isolates. We're allowed to, with our repository services and whatnot, able to molecularly characterize these. And then when other universities that have the ability to do this ask for isolates, we're able to send them out. We're able to send a lot of multidrug-resistant Acinetobacter isolates out because we have a large collection of them because we've been able to hold them. And these are clinical isolates that they actually need. So we partner with a lot of our civilian organizations. Dr. Smith talked about a lot of the funding. A lot of that funding actually goes out to civilian universities to do studies that we're really not equipped to be able to do. We're trying to focus more on the clinical end of things and directly with patients.
Mr. Chairman, one of the things that we try and do in DOD medical research is we try and target those areas that the civilian sector is not targeting. There's an extensive and has been mentioned extremely expensive program in Big Pharma to look for new antimicrobials. We have a few agents that we're looking at, some polypeptides and things like that, but the main focus is to partner to try to expand the indications for the new agents that a pharmaceutical company may be working with, to try and target the specifically difficult organisms or the organisms that are not seen commonly in civilian practice. And again, as Captain Martin mentioned, it's that partnership and the working with Big Pharma and other universities to enable to leverage our research dollars and our research interests with theirs.
Yes, sir. And if I may comment, I agree with what's been said by my colleagues to my left. There are a few specific areas of research that DOD is pursuing that may have some particular military usefulness, with human albumin plastic coatings of orthopedic implants, predatory bacteria microbial biofilms for the treatment of burns and wound infections, and a look at Staph aureus toxoid. So I think what we do have is a need for collaboration, coordination across many sectors, with DOD focusing on those areas of particular military interest, sir.
Do you think that you mentioned, I guess you, Colonel Javin, mentioned Big Pharma dealing with this issue. Are you convinced that there's adequate research going on in the private sector on resistant organisms? I mean, when you start looking at a specific gram-negative bacteria that has resistance, the number of cases, it can be devastating to a person, devastating to a hospital if they have to deal with it. Are the economics there to make it worthwhile for a company to invest in that kind of research? No, I mean, not even sure you're going to find a solution.
Sir, I'm unable to comment on what pharma may be investing.
Well,
I would.
We're talking about, you thought your niche was this, you had a specific niche, implying that there's the rest of us over in the private sector. I'm not convinced that there is adequate research going on in this area of looking for the next generations. Colonel Hospenthal, you have any comment?
I mean, from the non-DOD side, certainly the Infectious Disease Society of America, which we're the three consultants are members of, have identified this as a problem in getting new drugs, as has the similar counterpart in the EU. There isn't that many drugs in the pipeline. I think.
If I can interrupt, that's actually what led to this hearing today, was because, I don't know, sometime in the last couple of years, I became convinced that this is an example where the military is inheriting a problem, whether it's like lack of foreign language skills or whatever it is, and you're having to try to figure out how to solve it. But this is going to be a tough one to solve. If there's not, the reason there's not adequate dollars in the civilian side is because it would take a huge amount of money to find a new drug or two or three for a relatively small number of cases without much financial payoff. So then the question becomes, well, should we actually be beefing it up? Should that perhaps be a role that we could play? So that I'm interrupting you, but that's what led to this discussion, because I don't see them in the pipeline either.
Well, because of the cost and because of Big Pharma story, we have chosen to focus really the DOD research dollars on the wound, the colonization itself, the biofilms that are in the wound that allow these bacteria to, survive and develop resistance. And so it isn't that we're not doing research on antimicrobials. We're mostly have focused that on topical antimicrobials in the wound, immune response in wounds. How can we make that? A wound has to have bacteria in it. We have bacteria all over our body. So how can we keep the numbers of the bacteria down and not produce superbugs in those wounds? And that has been the focus that we've chosen with the research dollars over the last several years.
I just want to add to that as you suggest, the antimicrobial pipeline is really pretty empty. I mean, we don't have many new things coming down the line that look very promising for these really bad bugs. And as Colonel Hospenthal said, we're able to look at some other things other than antimicrobials to treat these. And I think vaccines have been a portion of this. So we have a major problem with Staph aureus infections in the military, especially in recruit settings, just because they're common skin flora. And MRSA, widely known all over, is a big problem for us as well. So we're partnering with pharma in looking at Staph aureus vaccines and doing those trials actually in troops in boot camp type setting to see, does this actually work in our setting, what we need in DOD? Not what we need in end-stage renal disease patients in an ICU somewhere, but what we need in DOD. And so there are other vaccine-type candidates. We have to look at, something was mentioned a little bit about phage. where viruses that will attack bacteria have been looked at. All of these are important other avenues besides antimicrobials that we are trying to pursue. And again, looking at the clinical end where the science meets the patient, because that's what we're having to deal with as the clinicians involved in caring for these patients.
And this whole lack of medication, people can't take a pill or have an IV to kill the bug that they have, that we got so used to over the last few decades, has brought us back to bedside care and scrupulous adherence to standard precautions. And if anybody shows any symptoms of something that might be contagious, we put a barrier between the healthcare provider and those moist body substances from the time they come back from overseas. And we use a long-acting chlorhexidine gluconate that stays on the skin for bathing these wounded warriors when they come back. And we find out as soon as we can that they are colonized or infected, so that we go back to basics to keep them as healthy as possible and not to share their bugs among themselves. It's real hard to keep Marine buddies away from each other when one of them is isolated and their buddy is in ICU and is not isolated. But we have, in special circumstances, we have dressed up a Marine dad so he could go in to see his baby born when he had Acinetobacter, when he had to do it on a video screen, and he and mom were able to know that they were there for each other.
Thank you. Mr. Whitman?
Thank you, Mr. Chairman. I think all these different pieces of the issue are very interesting in how they fit together and how we make sure that we're successful in the end. One of the critical elements, I believe, is the system of surveillance. How do we look at reporting and tracking these multi-drug-resistant organisms? How do we do that in our medical facilities? And let me ask this, can you all talk, and we'll begin with Dr. Smith, talk a little bit about the current surveillance system. Is it adequate? What does it focus on? Has it developed through the years? I know that the Army, I believe, has a system of tracking infections. I wanted to know a little bit about, is that maybe a model that should be used across all of our medical facilities? And this is both downrange and deployed facilities and non-deployed facilities back here stateside. So just a little bit about that and looking at the Army's multi-drug-resistant organism repository and surveillance network to see if that is maybe a paradigm that could be used, or what are the other services using as far as that effort to track and keep up with these organisms and the infections that go along with them. Dr. Smith, I'll begin with you, and then I'd like to get the other panel members' perspective.
Yes, sir. Thank you. I think we have, I would have to say we have a developing system of surveillance. It certainly has gotten better and better over time, and I mentioned a number of the elements of that network of surveillance. We're utilizing our armed forces health surveillance network. The global emerging infection system is out there gathering information from our overseas labs. We're participating now in NSQIP, the National Surgical Quality Improvement Program, which has a focus on infectious complications of surgery. We're participating in the National Healthcare Safety Network through the CDC, which gives us part of the picture. So we have a great deal of information that is beginning to be available to us, and those the NHSN, the NSQIP are relatively new for us. We're still looking at how we utilize those data. The services, as you've heard, do have some other parts of that picture. But let me, before I turn it over to them, let me say that they participate in our quality forum, which is run across service lines at the OSD level. And so we do have our infection prevention and control panel with the subject matter experts coming together to look at what can we see, what do we identify as problems, and what do we need to do about them in terms of both treatment, prevention, further surveillance, and also the research picture. So let me turn it over then to service representatives to address their specifics.
Well, this is certainly a huge problem, and the biggest issue that I see that is difficult to actually fix here is that if we had a single thing to track and follow around, this would be a whole lot easier. We could make it a reportable thing, call it brucellosis, and things would be much easier. Even the CDC doesn't see this as something that's easily put your arms around, because there's dozens of genus of these gram-negative rods. There's probably 100, 200 species of these gram-negative rods, and there's literally probably thousands of different genetic elements that cause these resistance patterns. And so if you put all those combinations together, they're hard to even decide what we're tracking and what we're looking to track with surveillance methodologies. And so even to pick up what we want to look for is difficult. Certainly the Marine and Navy Public Health Center is working this through the CHCS data, but it's very difficult. CDC guidelines, because of this, really are to identify issues at your own facility and individualize your response, and whether you conduct surveillance by doing cultures or by doing syndromic versus diagnostic results. Certainly, because of this, and because of the fact that a lot of these don't even track by ICD-9 codes, there's not an ICD-9 code for Acinetobacter, is one of the reasons that we actually put together the standardized screening at Landstuhl, National Naval, Walter Reed, and BAMC, is just so we could have an idea of how many of these Acinetobacters and how many of these other MDROs are coming through the door from the combat theater from Landstuhl as they transfer into the U.S. And so with the MRSN, the hope would be that this will help provide some answers with some tracking data from the JTTS and JTTR. The MRSN is housed as an Army program currently, but it's always been thought of as being a DOD program over the long term. And certainly, my Navy and Air Force colleagues were involved in, and still are involved in running that program. That program is based at the Walter Reed Army Institute of Research, but it certainly gets National Naval Medical Center isolates, Landstuhl isolates, et cetera.
Just to add on to what Colonel Hospenthal said, I think that this is also an issue of trying to track these things where you don't know if a patient is colonized or infected. You don't know if we get asked how many of these you have. Well, do you count the one that the same patient has had multiple times in the lab over a long period of time? It becomes really difficult to track. We have been able to, and it was just alluded to through the Navy Marine Corps Public Health Center, looking at the CHCS computer system that's used DOD-wide, now able to really look at they're trying to get all the hospitals to report resistance the same way so they can look at this. But this whole question about the recent superbug coming out of India, NDM1, we're asked, how much of this are we seeing in the Navy and Marine Corps? Very quickly able to go through and say, we're not seeing any of this. We haven't seen any isolates of this. We could go through and look at all of the stuff in the repository and say, there is not any of this. The study I talked about, TDOS, the Trauma Infectious Disease Outcome Study, is really collecting all of these specimens from everybody, Army, Navy, Air Force. Even though it's a Navy-funded program, most of the work is actually done at Army hospitals. All of those isolates are collected. We're able to save them and see what is going on and have a pretty good handle now, which we really didn't 5 or 6 years ago, on what's going on with MDROs. So.
Infection control-wise, in the Navy and Army, for patients who have MDROs or some other epidemiologically important pathogen, since the BRAC is coming soon, Walter Reed and National Naval Medical Center have become closer and closer, and we have devised identical protocols. And we put, for bed management, if a patient has ever had an MDRO, we have them listed. We note that in ALTA and or CHCS, so the bed manager will note when they come back to the clinic or as an inpatient, and puts them on appropriate transmission-based precautions. And this is communicated among the different services, and as people are sent to San Antonio to go back closer to home. But inside the Beltway is where this started. We also devised a clearance culture protocol using the ID and infection prevention people from Walter Reed and National Naval Medical Center in congruence with the Centers for Disease Control, because it's so hard to keep people on isolation precautions when they feel better, they're not dripping anymore. Do we have to stay here? Can't I go visit my buddy? And we devised a protocol so that there are 3 screenings at least 72 hours apart when a person has been off all antimicrobial therapy for the bug for at least 72 hours. And this was agreeable to all 3 places. And that was a first to get people off isolation without having to wait weeks or months.
I think, as all the folks up here have expressed, that this is really a process and evolution, and I think we have some very good basic surveillance going and some platforms that are going to help us to answer a lot of these questions. With these MDROs, it's a little different than some of our tried and true reportable diseases like tuberculosis, where we have a very long history of managing this, very good guidelines of how we do it, and it's all reported. I think we're still defining what an MDRO infection is in some places and what colonization versus true infection means. And as the network that I think we have set up across the services continues to evolve, we'll be able to provide better answers and then provide maybe that guidelines out there that would then better define exactly what these entities are and how to address them.
Sir, can I add one thing? I also, not to toot our own horns, but I think in infectious disease and infection control communities in the DOD are probably one of the more united groups of anywhere in medicine in the DOD. We have, we cross-train at Bethesda and Walter Reed, we're Army and Navy. In San Antonio, we're Army and Air Force. We swap staff around frequently. We have a very good idea of what is going on. And so when we talked about this before, it was hard for us to separate out what we would do individual in each service, because we really do this very much in a unified fashion, which I think is the best way for our patients and the best way overall for the way we want to go with this.
And for the sake of our transcriptionist, that swap staff was with a double F and not a PH, right? Thank you. I want to ask Ms. English, you talked very eloquently about really getting in the prevention aspects of it. Have you seen a difference over time, over the last several years, once an infection has been diagnosed, in terms of how well patients have done, as you've tracked that over the last 6 or 7 years, once they're diagnosed with an infection? Apparently not a dramatic improvement.
I think that's a tough question, and I think it's a very good question. It's I think that we are much more sensitive to the fact that we have to be ready to treat an MDRO right up front much more quickly. So we tend to collect our samples and maybe more broadly treat with antimicrobial therapies up front than we would have before, which may give us a day or two jump on this before material comes back from the lab. And we also have a pretty robust discussion among ourselves about how do you want to tackle this one. This patient has renal failure, and on top of it, it has this MDRO and these other issues going on. So because these are tough clinical cases to handle very frequently. So I think we are a little faster to be able to get that together than maybe we were at first when we were a little more shocked by these. I don't know if you have any comments to add, Colonel Forgione, or?
No, I would agree with that. We've also made ourselves and our surgical colleagues aware that just looking for bacteria because it might be there is not always the best idea. And so we do not swab wounds like we used to when we first started thinking about Acinetobacter and just treating the colonization. So we really have become more sophisticated into only treating folks who clearly have infections. That way we're not exposing our folks to some of these older and more toxic agents. Overall, I think patients are doing better, but that's, you know, my anecdote, my opinion. The TDOS study certainly will give us that data on how folks were treated, what works best. The orthopedic groups in the military and across the civilian are doing some larger studies for prevention with irrigation pressures, irrigation fluids, irrigation additives. For most of these are traumatic extremity injuries, and so there is major funding for that research that is being done multi-center and internationally, and I think that data will help us as well. We have developed prevention guidelines that talk about peri-injury antibiotics, debridement, irrigation, et cetera, and that is a DOD, Army, Air Force, Navy program. We are actually in the middle of revising those guidelines and doing an update for prevention. And I guess one side note, during all of this, we noticed that minocycline was actually an effective old drug for this, for at least the Acinetobacters, and we did work with the company that actually owned the license for intravenous minocycline to get it back on the market. It was still approved. It is now available again.
Colonel Hosmithl, I want to be sure I understand what you were saying about the irrigation. The studies on irrigation, are you saying that sometimes there's inadequate irrigation in terms of cleansing, or you can fire hose it away to where you devitalize some tissue?
Right. Probably the latter is more important. I mean, no one really knows how much irrigation fluid to use, but right. Is that really important? You need to use it how much you need to get all the visible junk out of there. More important is the pressure. There is a division among surgeons and in the literature, both basic research and animal research and clinical trials, that high pressure is better because these explosive IED blasts push things up in there and we need to get them out so they don't become nidus of infection, versus high pressure is really only used to chisel away at bones and take out bone marrow, and you shouldn't be using high pressure and causing more tissue damage that then might get infected. And so trying to sort out which of those actually is the better approach is being funded as a clinical trial. And then there's the debate, you know, naturally you're thinking, if I'm pushing fluid up in there, wouldn't it be better to have some antimicrobial or antiseptic compound in that fluid? Well, the research on that is all over the board as well. A lot of the things that we would put in fluid to irrigate actually kills bacteria, but it also kills growing and granulating tissue, and so it may cause delayed healing that then does get infected. And so there are research projects into looking at additives for irrigation fluid as well.
I can't let you all get out of here today without at least having you respond to the following question. I had a discussion this morning with somebody who works on the Hill expressing their disappointment about going to the doctor yesterday with about a day and a half of a cold, and the doctor just flat out refused to give them antibiotics, and this person was incensed that that was the case and probably was doctor shopping. Any one of you want to comment on the issue of the proper use and overuse of antibiotics and its relationship to these challenges you all are talking about today?
Sir, I think you've hit one of the big problems around the world, is that the expectation that anything that you go to a doctor for needs antibiotics to cure. We have aggressively taught that to all our healthcare providers, all our healthcare team, that you only use antibiotics when clinically indicated, and you use the most specific antibiotic for that particular organism to prevent the growth of drug resistance.
I think it's a very, very interesting question, and I've found kind of a dichotomy that here in the U.S., because people now have heard about the overuse of antibiotics, in some people it's been easier to tell them You don't need an antibiotic for this. I think, as the Colonel just mentioned, the problem is in a lot of the rest of the world. And I've lived and worked overseas before in Latin America, and we're seeing this now with the bugs coming out of India. A lot of the other world, the rest of the world, you can just go and buy antibiotics. And people frequently do and take a day or two or a dose or two of all kinds of antibiotics. So we see some of the most resistant bugs coming out of the developing world, where you wouldn't expect that they'd have ready access to some of these, but they do. So we see whether it's multi-drug-resistant salmonella infections out of Southeast Asia or sexually transmitted infections, big problems with this. And a lot of it is inappropriate use of antibiotics. I think we have a lot of inappropriate use in the U.S. still, not nearly as what we had before. And the example you brought up is, I think, the most common one. I mean, busy physicians who have 6.5 minutes to see a patient, sometimes it's easier to pull out the script pad and give them what they want than it is to talk them through the fact that they have a viral infection.
Excuse me, but on the other hand, this weekend starts the 2010-11 flu season. And if your colleague had a fever above 100.4 and upper respiratory symptoms, he would be wise to consult with his primary care provider to receive oseltamivir if he hasn't received his flu shot by now.
Anything further?
Yeah, just one additional question. This is a little bit in the weeds, but I noticed, Ms. English, you made reference to pulsed field as one of the treatments. I know I was intrigued by some of the research that's going on out there with actually accelerating wound healing with that technology. And I know that in my previous life and working in public health, there was a lot of research there as far as food safety and having it as an antimicrobial agent in food preparation. But I'd be interested to hear a little bit more from you about the future of that technology and the applicability there as far as infection control.
I think there was a little confusion. What she was talking about was pulse field gel electrophoresis, characterizing organisms, which is a different thing than what you're talking about, which is also being looked at. And in fact, in the new hospital, the new Bethesda that we're building, they're looking a lot at using some pulses of ultraviolet and whatnot to knock down contamination in ORs and in rooms. So that is another moving area that is really important, especially when you're talking about organisms that are even becoming resistant to some of the topical antimicrobials that we use. So that is ongoing research as well.
Thank you all for your time today, and thank you for the work that you do. I will leave it as an open-ended question for the record. If you all, any of you have anything additional you'd like to add, please send it to the staff here in the next week or so, and we'll get it to the members and also include it as part of the record of this hearing. And I hope as time goes by, as you all think or continue thinking about these issues, if you see a further congressional role in this, I hope you'll let us know, because we'd be very receptive to doing what we can. If it's a funding need or whatever it is, we would certainly be glad to look at it if you see some additional needs there that are not being met that Congress can play a role in. Thank you all very much. The hearing's adjourned.